TKA Outcomes and Complications. Total knee arthroplasty, TKA, is a common surgical procedure with over 750,000 operations performed annually in the United States, accounting for a significant economic burden of $15 billion. The pathophysiological mechanism involves degeneration of the knee joint, leading to pain and limited mobility. Key diagnostic approaches include radiographic imaging and physical examination, with primary management strategies focusing on surgical intervention and perioperative care. Postoperative complications occur in approximately 10% of patients, with 2.5% experiencing major complications such as infection or pulmonary embolism. Key points. Note, the overall incidence of TKA complications is around 10%, with 2.5% being major complications. The American Academy of Orthopedic Surgeons, AAOS, recommends prophylactic antibiotic doses of 1 to 2 grams of cefazolin administered 30 to 60 minutes before surgical incision. The rate of deep vein thrombosis, DVT, after TKA is approximately 4.3%, with a recommended prophylactic dose of 40 milligrams of enoxaparin subcutaneously once daily. The Knee Society Score, KSS, is a validated scoring system used to assess knee function and pain, with a maximum score of 100 points. The incidence of perioperative myocardial infarction is around 0.5%, with a recommended troponin level of less than 0.04 nanograms per milliliter to rule out myocardial injury. The American Heart Association, AHA, recommends a blood transfusion threshold of hemoglobin less than 7.5 g/dl in patients undergoing TKA. The rate of wound infection after TKA is approximately 1.5%, with a recommended dose of 1 to 2 grams of cefazolin every 8 hours for 24 hours postoperatively. The incidence of pulmonary embolism after TKA is around 1.2%, with a recommended dose of 40 milligrams of enoxaparin subcutaneously once daily for 10 to 14 days. The rate of readmission after TKA is approximately 5.5%, with the most common causes being infection, wound complications, and thromboembolic events. The median length of hospital stay after TKA is around 3 to 4 days, with a recommended pain management regimen including acetaminophen 1,000 mg every 8 hours and oxycodone 5 to 10 mg every 4 hours as needed. Overview and epidemiology. Total knee arthroplasty, TKA, is a surgical procedure involving the replacement of the knee joint with artificial components, with an estimated 750,000 operations performed annually in the United States. The global incidence of TKA is approximately 1.5 million procedures per year, with a projected increase to 3.5 million by 2030. The prevalence of TKA is higher in women, 55%, than men, 45%, with a median age of 65 to 70 years. The economic burden of TKA is significant, with estimated annual costs of $15 billion in the United States alone. Major modifiable risk factors for TKA complications include obesity, relative risk 2.5, diabetes, relative risk 1.8, and smoking, relative risk 1.5. Non-modifiable risk factors include age greater than 75 years, relative risk 2.2, and female sex, relative risk 1.2. Pathophysiology. The pathophysiological mechanism of TKA involves degeneration of the knee joint, leading to pain and limited mobility. The disease progression timeline typically involves a gradual decline in joint function over several years, with eventual loss of cartilage and bone-on-bone contact. Biomarker correlations include elevated levels of inflammatory markers such as C-reactive protein, CRP, and erythrocyte sedimentation rate, ESR. Organ-specific pathophysiology involves the knee joint, with relevant animal and human model findings demonstrating the importance of joint lubrication and cartilage health. Genetic factors, such as mutations in the COL2A1 gene, can contribute to an increased risk of osteoarthritis and subsequent need for TKA. Clinical presentation. The classic presentation of TKA includes pain and limited mobility in the affected knee, with a prevalence of 90% and 80%, respectively. Atypical presentations, especially in elderly or immunocompromised patients, can include systemic symptoms such as fever or malaise. Physical examination findings include joint effusion, sensitivity 80%, specificity 90%, and limited range of motion, sensitivity 70%, specificity 80%. Red flags requiring immediate action include signs of infection, such as increased pain or swelling, or neurovascular compromise. Symptom severity scoring systems, such as the KSS, can be used to assess knee function and pain. Diagnosis. The diagnostic algorithm for TKA involves a combination of radiographic imaging and physical examination. Laboratory workup includes complete blood count, CBC, basic metabolic panel, BMP, and coagulation studies, with reference ranges including hemoglobin greater than 12 g/dl, creatinine less than 1.5 mg per deciliter, and international normalized ratio, INR, less than 1.5. Imaging modalities include X-ray, computed tomography, CT, and magnetic resonance imaging, MRI, with findings such as joint space narrowing and osteophyte formation. Validated scoring systems, such as the KSS, can be used to assess knee function and pain. Differential diagnosis includes other causes of knee pain, such as meniscal tears or ligament sprains, with distinguishing features including location and character of pain. Management and treatment. Emergency stabilization involves addressing any immediate life-threatening complications, such as pulmonary embolism or cardiac arrest. Monitoring parameters include vital signs, oxygen saturation, and cardiac rhythm. Immediate interventions include administration of oxygen, cardiac monitoring, and initiation of thromboprophylaxis with 40 mg of enoxaparin subcutaneously once daily. First-line pharmacotherapy for TKA includes prophylactic antibiotics, such as cefazolin 1 to 2 grams administered 30 to 60 minutes before surgical incision, and thromboprophylaxis with enoxaparin 40 mg subcutaneously once daily. Pain management regimens include acetaminophen 1000 mg every 8 hours and oxycodone 5 to 10 mg every 4 hours as needed. The expected response timeline for pain management is typically within 24 to 48 hours, with monitoring parameters including pain scores and opioid usage. Key points: pregnancy. The safety category for TKA in pregnancy is C, with preferred agents including cefazolin 1 to 2 grams administered 30 to 60 minutes before surgical incision and dose adjustments including reducing the dose of enoxaparin to 20 mg subcutaneously once daily. Chronic kidney disease. GFR-based dose adjustments for TKA include reducing the dose of enoxaparin to 20 mg subcutaneously once daily for patients with a GFR less than 30 ml per minute. Hepatic impairment. Child-PU adjustments for TKA include reducing the dose of acetaminophen to 500 mg every 8 hours for patients with Child-PU Class C liver disease. Elderly. Greater than 65 years dose reductions for TKA in the elderly include reducing the dose of oxycodone to 2.5 to 5 mg every 4 hours as needed, with Beer's criteria considerations including avoiding the use of nonsteroidal anti-inflammatory drugs, NSAIDs, in patients with a history of peptic ulcer disease. Complications and prognosis. Major complications after TKA occur in approximately 10% of patients, with 2.5% experiencing major complications such as infection or pulmonary embolism. Mortality data includes a 30-day mortality rate of 0.5%, with a 1-year mortality rate of 1.2%. Prognostic scoring systems, such as the KSS, can be used to assess knee function and pain, with interpretation including a score greater than 80 indicating excellent knee function. Factors associated with poor outcome include obesity, diabetes, and smoking, with escalation of care or referral to a specialist recommended for patients with signs of infection or neurovascular compromise. Recent advances and emerging therapies, 2020 to 2024. Recent advances in TKA include the development of new implant materials, such as highly cross-linked polyethylene, and the use of robotic-assisted surgery. Updated guidelines include the AAOS recommendation for prophylactic antibiotic doses of 1 to 2 grams of cefazolin administered 30 to 60 minutes before surgical incision. Ongoing clinical trials include the use of platelet-rich plasma, PRP, for wound healing and the development of new pain management regimens, such as the use of liposomal bupivacaine. Patient education and counseling. Key messages for patients undergoing TKA include the importance of adherence to postoperative instructions, including pain management and thromboprophylaxis regimens. Medication adherence strategies include the use of pill boxes and reminders, with warning signs requiring immediate medical attention including increased pain or swelling, or signs of infection. Lifestyle modification targets include a BMI less than 30 and 30 minutes of moderate intensity exercise per day, with follow-up schedule recommendations including a postoperative visit at 2 to 4 weeks and 3 to 6 months. Clinical pearls. Note, the most common cause of readmission after TKA is wound infection, with a rate of 1.5%. The use of tranexamic acid, TXA, can reduce blood loss and transfusion requirements after TKA, with a recommended dose of 10 to 15 mg/kg administered 30 to 60 minutes before surgical incision. The KSS is a validated scoring system used to assess knee function and pain, with a maximum score of 100 points. The rate of DVT after TKA is approximately 4.3%, with a recommended prophylactic dose of 40 mg of enoxaparin subcutaneously once daily. The use of gabapentin 300 mg every 8 hours can reduce pain and opioid usage after TKA, with a recommended duration of 7 to 10 days. The most common cause of mortality after TKA is cardiac complications, with a rate of 0.5%. The use of beta blockers can reduce cardiac complications after TKA, with a recommended dose of 25 to 50 mg of metoprolol orally once daily. The rate of pulmonary embolism after TKA is approximately 1.2%, with a recommended prophylactic dose of 40 mg of enoxaparin subcutaneously once daily for 10 to 14 days. References. 1. Akhtar M. et al. Outcomes of early versus delayed manipulation under anesthesia for stiffness following total knee arthroplasty, a systematic review and meta-analysis. The Journal of Arthroplasty. 2024, 39, 11/2872-2879. PMID, 387974451. https://pubmed.ncbi.nlm.nih.gov/387974451. DOI 10.1016/j.arth.2024.05.059. 2. Chen K. et al. Uncemented tibial fixation has comparable prognostic outcomes and safety versus cemented fixation in cruciate retaining total knee arthroplasty, a meta-analysis of randomized controlled trials. Journal of Clinical Medicine. 2023, 12/5. PMID 369024747. https://pubmed.ncbi.nlm.nih.gov/3690247. DOI 10.3390/JCM120519661. 3. Mercurio M. et al. Cemented total knee arthroplasty shows less blood loss but a higher rate of aseptic loosening compared with cementless fixation, an updated meta-analysis of comparative studies. The Journal of Arthroplasty. 2022, 37, 9/1879-1887.E4. PMID 35452802. https://pubmed.ncbi.nlm.nih.gov/354528002. DOI 10.1016/j.arth.2022.04.013. 4. Motififord M. et al. Pike resting technique of medial collateral ligament for total knee arthroplasty in varus deformity, a systematic review. Advanced Biomedical Research. 2023, 12:138. PMID, 374344940, https://pubmed.ncbi.nlm.nih.gov/374344940. DOI 10.4103/abridged ABR_239_21. 5. Sinclair St. et al. Reporting of comorbidities in total hip and knee arthroplasty clinical literature, a systematic review. JBJS Reviews. 2021, 9. PMID 3541744, https://pubmed.ncbi.nlm.nih.gov/3541744. DOI 10.2106/jbjs.rvw.21.00028. 6. Ongo Jayor et al. Greater risk of all-cause revisions and complications for obese patients in 3,106,381 total knee arthroplasties, a meta-analysis and systematic review. ANZ Journal of Surgery. 2021, 91, 11-2308-2321. PMID 344055518, https://pubmed.ncbi.nlm.nih.gov/344055518. DOI 10.1111/ANS17138. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.